It is a pleasure to be here. We all work together in various facets, in various disciplines, and I'm very honored to see such a wide interest in inflammatory cerebrovascular disorders. As Tina mentioned, I am a cerebrovascular neurologist, but also trained in neuroimmunology, and the intersection of those are kind of where my clinical interest and research interest lies. So the goal of today's talk is not to, I don't expect that people are going to walk away from this talk and go treating these patients, but all of you have or probably will see patients with inflammatory cerebrovascular disorders. And I can tell you, even to the general neurologist, practicing general neurologist, or the vascular neurologist even, these are scary disorders. When people present with anything inflammatory, or even when someone presents in a very complex fashion, inflammation comes up so many times that, oh wow, this looks really aggressive. Are we dealing with an inflammatory cerebrovascular disorder? And the goal of today's talk is to talk a bit about the diagnostic dilemmas that we have in diagnosing some of these inflammatory cerebrovascular disorders, the therapeutic frontiers of how we can go about managing them and what is in the pipeline, and then future directions of where we're heading. But overall, my hope is that when you leave this talk today, you'll be able to be more familiar with some of these inflammatory cerebrovascular conditions and the journey that these patients have and how difficult and complex they can be. I mean, most of you all who deal with cerebrovascular disorders, you're very familiar with, hey, aspirin or Plavix and vascular risk factor control, sure. But what do we do when there's inflammation in the blood vessels? It's much more than that, and it's controlling inflammation. It's trying to first diagnose inflammation. I think one of the greatest dilemmas that the vascular neurology or general neurology field has clinically is how to make the right diagnosis. And we'll talk about why it's so important to make this right diagnosis. I realize that my audience is a bit postprandial, so I'll try to keep you all up to consciousness here, but no dozing off, hopefully. The objectives of my talk today are to discuss, again, as I mentioned, when to consider an inflammatory cause of a stroke, when we think about how to clinically diagnose, and how we approach these in a very clinical and diagnostic fashion. And I'll refer to inflammatory cerebrovascular disorders as ICDs in my talk. And then we'll discuss a case-based approach, highlighting some of the diagnostic dilemmas and therapeutic approaches to some of the inflammatory cerebrovascular conditions and some current and future directions in research. I will say this inflammatory cerebrovascular disorders topic has been a symposium, a full-day symposium on its own. And still, you can't go over everything, but I'll try to just give you a brief preview of everything. So when in neurology do we think of an inflammatory cause of stroke? It's usually when you have patients, particularly younger patients, who present with not much vascular risk factors, and they're presenting with stroke after stroke after stroke. Or particularly when patients present with a stroke in the setting of a blood vessel problem on imaging, like what we call a vasculopathy. So vascular irregularities on imaging, we call them vasculopathy. But all you can tell on an imaging is that there's abnormal vessels. You can't tell if they're inflamed or not unless you actually go in there and do spinal fluid testing, or there's other imaging modalities, which I'll talk about briefly, or you have a biopsy. But on the looks of it, sometimes very aggressive things can look like they're inflammation, and sometimes they are, but sometimes they're not. But there are sometimes symptoms of inflammation that can be headaches, progressive encephalopathy, and confusion. Someone's presenting with months of kind of just slowing down, along with headaches, sometimes seizures, and then they have strokes. Sometimes it's important to step back and put all those together. This is a person who came in has been having headaches, they have this blood vessel problem, they've been having strokes, we don't really see much vascular risk factors. That all should prompt us towards looking towards an inflammatory cause of stroke. And then sometimes we'll have infarcts in various disseminated areas and blood vessel abnormalities, and that person gets a spinal fluid testing or spinal tap for some reason, and we see that there's an inflammatory spinal fluid. Or again, recurrent strokes in patients who, despite vascular risk factor control, they have strokes again and again. That last one is probably one of my most common referral reasons from other colleagues that, hey, this person, we have all their vascular risk factor controls, but these strokes are just not stopping. Should we be thinking of an inflammatory cause of stroke, an immune-mediated cause of stroke in these patients? For example, here's a 60-year-old patient presenting with headaches and subacute cognitive decline. By subacute, I mean weeks to months. And she has all these different infarcts on MRI. And again, they're small vessel infarcts. The large vessels look overall stable. Here's a 20-year-old girl who presented with a large right hemispheric stroke in the setting of this vasculopathy. So on imaging, as you can see here, right, normal vessel all the way up top, and then look at that right MCA, and also the left side doesn't look too great either. So that is something that should make us think of a 20-year-old, no vascular risk factors, headaches, and a vasculopathy or blood vessels that looks like that, and a stroke. That's when we should think about an inflammatory cause. Or a 64-year-old man with progressive cognitive decline over 4 months, and an MRI brain showing infarcts kind of over various time. You can see some are brighter than the other. And then this is diffuse blood vessel abnormality. You can see all of them look very ratty and irregular. Or this 49-year-old woman, as you can see, I'm showing you, anywhere from 20 to 70, 80-year-olds, right, and in between. Inflammatory causes of stroke don't spare anyone. And this is a 49-year-old woman with progressive cognitive decline over a few weeks, and then vision changes, and MRI brain showing, small vessel infarcts there, which we'll talk about in a bit. So one of the greatest diagnostic dilemmas I was mentioning that the common neurologist sees is when patients present with stroke in the setting of vasculopathy, they may have some vascular risk factors, but things just 1 + 1 doesn't add up, right? And so this is, for example, a patient with a 49-year-old man with a left MCA syndrome and left MCA strokes there on infarcts and MRI, and that blood vessel that looks a little irregular. So how do we approach this patient? Because this is a case that was actually sent to me specifically asking, we have done vascular risk factor control pretty reasonably. They keep stroking out. Should we think about an inflammatory cause of stroke? And I actually think this was Tina's team that actually sent this patient after an angiogram to me to say, hey, should we be thinking of an inflammatory cause here? So just in a quick nutshell, again, I'm not going to go over the clinical practice issues too much, but we look for patients who present with the right clinical features of inflammation, like headaches, encephalopathy, seizures. We look to see infarct pattern on MRI. It can really tell us, is this more of a big vessel stroke or a small vessel stroke? And if it's a big vessel stroke, yes, go do imaging and looking at the bigger vessels. But if it's a small vessel stroke, then we have to look at more tiny vessel imaging, which is MRI brain with contrast can give us that. We'll do a diagnostic cerebral angiogram. You wonder, why does that patient get a diagnostic cerebral angiogram, which is an invasive procedure, which we go in and kind of thread a catheter and take a lot of pictures in a fluoroscopy-guided CT room to kind of look at the more in-depth blood vessels further up, kind of the tertiary, quaternary branches. So when there's small vessel vasculitis, or we're concerned of a small vessel problem, then we do an MRI brain with contrast, which can pick up some leptomeningeal inflammation in the brain. And then a cerebral angiogram can look much further than, say, for example, that MRA just looked at, right? So we look for a blood vessel problem, and now we've identified, okay, well, this patient came in with the right clinical symptoms to suggest inflammation. They have strokes on MRI, or infarcts, as we like to call them, and then they have a vasculopathy, blood vessel abnormality. Now, the biggest question is it inflammatory or not? Is this just run-of-the-mill blood vessel problem from plaque buildup, et cetera, or is there actual inflammation? And yes, a brain biopsy would tell us, right? But sometimes brain biopsy, particularly most often, the area involved is just too eloquent and it's too dangerous to go in. Are there other modalities, less invasive, that can tell us? Well, yes. And how do we tell that? So spinal fluid analysis can be very helpful. This fluid that bathes the blood vessels around the brain circulates throughout the spinal canal, and we're able to tap a needle in the lower spinal canal where there's no spinal cord and just a pocket of fluid, and take that fluid. And we assume that if there's inflammation in the blood vessels, it'll be picked up in that fluid, and we'll be able to test it. And the other thing is vessel wall imaging, which I'll talk about. So spinal fluid, we're really just looking for inflammatory spinal fluid. These numbers you don't have to worry about, but they're beyond normal. So if you have a little bit, like normally 5 or less cells is normal, but when you have inflammation, particularly if it's immune-driven, you should see about 15, 20, 30 cells. But when you see like 300 cells or sky-high protein, that's when we should think about other things like infections and cancer and things like that. So vessel wall imaging was one of my favorite topics, and I use it a lot in my clinical research and in clinical care. This is basically imaging that suppresses the blood sequence, and with contrast is given, and it is able to pick up contrast in and around blood vessels and can pick up any inflammation or plaque. And there's certain enhancement patterns that we can use. So when it's like really thick concentric enhancement that suggests more inflammation. Now, it's not going to tell you if the inflammation is from like an infection or some other autoimmune condition, but all it'll tell you is this looks more like plaque, this looks more like inflammation, go figure what it's from, and then this looks normal. But it's very, very helpful oftentimes. So we can use those things to understand, is there inflammation or not? But then once there is inflammation, the next thing we ask, okay, is this inflammation just confined to the brain? Or is it maybe inflammation from another systemic disorder in the body that went to the brain, or from something secondary like infection or cancer? And that's when we kind of go down this algorithm here, which we're able to kind of, up until now, establish that there's a vasculopathy, it's inflammatory. Then we do a bunch of tests in the blood to rule out other systemic inflammatory causes. We do other infectious studies in the spinal fluid to rule out inflammatory and neoplastic causes. And then we'll do some systemic imaging to look for any large vessel systemic involvement, if there's large vessel involvement in the brain, or if there's a lot of small vessel inflammation that we see, then sometimes a PET CT can be very helpful. So again, we're ruling out other causes. Here's a long list of things, which again, I just wanted to show you that there are things from immune-mediated, infectious, cancer, other vasculopathies, even genetic, that can cause various different types of inflammatory conditions in the brain. And again, when we look at things from a frame of, is this large vessel, is this small vessel, or is it diffuse, it kind of helps us narrow that differential. What the dilemma that I feel that most of kind of the neurology community goes through is when there's an inflammatory disorder workup patient admitted, they get like the $1 million workup. Everyone's doing every test they can, which I think is very poor yield, and we're not using our resources well in that setting. If we understand, for example, there are some things that only cause small vessel vasculitis. They will never cause large vessel vasculitis. And if you do all those panels of small vessel vasculitis when someone has large vessel involvement, it's all going to be normal. So it's all redundant. Versus if someone has a large vessel vasculitis and vice versa, then you should be doing kind of systemic body scans, looking at bigger vessels in the body. Whereas if someone has a small vessel vasculitis and you're doing big vessel scans on the body, you're just putting them through all this radiation for nothing. And I feel like sometimes we treat ourselves and our anxiety and our kind of, we want to be, quote, thorough, but really it's redundant testing often in these patients. And then we can do a PET CT, which is really good at picking up inflammation in the rest of the body. And then ultimately, depending on what we see, if we can, a brain biopsy is always recommended to rule out, other infection or cancer. And the reason is that if you make a wrong diagnosis of vasculitis, and vasculitis is treated with immunosuppression and chemotherapeutic agents, what do those things do? They certainly, when they're absolutely necessary, that's the only thing that'll treat underlying inflammation. But those are immune suppressants. They can increase your risk of infection. Particularly, we give these people steroids, high doses of steroids up front to reduce the inflammation. What do those steroids do? They're going to cause increased blood pressure, increased glucose, worsen diabetes, high plaque, cholesterol. So this misdiagnosis can be very costly to the patient and would have a lot of bad consequences, right? So that's why we try to do a brain biopsy kind of focused. But what do we do in cases when we don't have a brain biopsy? Or, there's a process that's just so focal in the left hemisphere and, we can't biopsy that place. Sometimes doing a non-dominant biopsy or going elsewhere if it's more of a diffuse process may help. But if it's only this little area and you go, it's like one slice of an orange is bad, all the others are totally fine. And if you go sample another slice, it's going to be completely normal, right? Does that mean that one slice that's affected isn't affected, or did you just have a sampling error and you didn't sample the right place? But sometimes you just can't sample the right place because it's just too high risk or deep in the brainstem. So overall, kind of that whole scenario that I showed you here, from someone with clinical features, the right imaging features, ruling out kind of other things systemically with blood work, CSF testing, systemic imaging, where indicated, trying to minimize redundancy. So coming back to this patient, 49-year-old man, presented with a left MCA stroke. He had this blood vessel abnormality, right? And on CT, and then got a cerebral angiogram and had this vasculopathy. And they're like, okay, well, this probably looks like athero. We don't really see, we'd see like maybe 2 vascular risk factors, hypertension, hyperlipidemia. we'll control it. They put the person on aspirin, Plavix, and vascular risk factor control with statin. And then next time the patient comes in with even worse vasculopathy on the left, and now the right side is also involved. And that's when this patient was referred to the vasculitis clinic. I should mention, we're very proud. We're the only center in the entire country, arguably in the world, that has a dedicated cerebrovascular inflammatory disorders clinic that we've been able to develop here. And so we get a lot of patients to this clinic. I've had patients all the way from Hawaii to Australia and everything in between come there. And so this patient was actually seen here at the Cleveland Clinic, and that's when they were like, okay, well, we've treated them with all the regular things, the aspirin, Plavix, high-intensity statin, but this patient keeps having stroke. Is this vasculitis? Is it intracranial atherosclerotic disease or plaque buildup? I mean, the patient's still fairly young, so what do? Do we start the $1 million workup for vasculitis? And that's a frequent dilemma that we see, is differentiating atherosclerosis from inflammation. Now, imagine someone with atherosclerosis, and this has happened too many times, someone with just plaque buildup. Clinicians are thinking, oh, this might be inflammation, and they go down that rabbit hole of inflammatory disease. And trust me, even despite spinal fluid testing and vessel wall imaging, misinterpretation of vessel wall imaging is so common. People will call vasculitis on something that's not. People will call inflammation on spinal fluid testing, particularly where it's difficult to differentiate sometimes. You do a bloody spinal tap and there's a lot of blood cells, you're going to have protein, you're going to have cells. But is that just because it's a traumatic bloody tap, or is it because there's actual inflammation? And so, sometimes it can be very difficult to differentiate those unless you really kind of hone in on vessel wall imaging features or, have a really clean spinal tap. But most importantly, it's the clinical features in the whole story. I often say vasculitis or inflammatory cerebrovascular disorders are a clinical radiographic diagnosis. You can't call vasculitis on an image alone. You can't call it on seeing a patient alone. It's everything together, right? So coming back to the dilemma is that imagine a patient with vasculitis gets missed and they think it's plaque, and that person, vasculitis can be really aggressive. That patient will keep having stroke after stroke after stroke, because we just think it's not vasculitis and we're not even looking there. On the contrary, someone has plaque from high blood pressure, high cholesterol, diabetes, and they're misdiagnosed as vasculitis. And they're put on steroids and immunosuppressants and have increased infections. And what's going to happen with those months' worth of steroids? Their blood pressure is now higher, their cholesterol is higher, their diabetes is higher, their plaque is going to be more. I've had patients refer to me who are actually atherosclerosis, mislabeled or misdiagnosed as vasculitis, treated with steroids, came back with more blockage of those plaque buildup vessels. And you know what they refer to me for? We think this patient has resistant vasculitis. It's resistant to steroids, right? If it's resistant to steroids, you're on the wrong path, right? And that's why it's very important that we try to make this right diagnosis. So this has been my dilemma as a resident when I was in training. And fortunately, here we're able to build this cohort of patients with, because literally my clinic helped me build this cohort, because I had all these patients who were referred with plaque, and we were diagnosing them with, they were previously diagnosed with vasculitis, and we were able to kind of come up with a rational kind of retrospective study in which we looked at vessel wall imaging characters, clinical features, and CSF findings combined together. We looked at 20 different segments of the vessel wall, of the circle of Willis in the brain, looked at vessel wall segments, looked at certain things of regularity versus irregularity, came up with quantitative ratios of, if it's more concentric and less irregular, and you have inflammation in the spinal fluid, and you have the right clinical features, by all means, make that diagnosis. Particularly in patients when you don't have a brain biopsy, these features can be very helpful. But if it's not, then it's likely atherosclerotic disease. And so this patient, based on our study, had no headache, encephalopathy, or seizures. The vessel wall MRI findings fit very well with atherosclerotic disease, and therefore this patient was ultimately diagnosed with intracranial atherosclerotic disease. And when we down went as well, this person was actually resistant to Plavix. They just couldn't metabolize it. They still hadn't seen endocrinology. Their diabetes still wasn't very well controlled. And, we definitely could have done a better job. I mean, we made it, more than 70% of the way with their cholesterol control, but that just wasn't enough, right? We needed to, particularly with vascular controls, for example, studies show that statins alone, like if you're sitting at an LDL of 200 and your goal is 50, putting them on 80 of atorvastatin is not going to get you from 200 to 50. It'll bring you down to 100, but definitely not to 50. But if you add things like ezetimibe, the likelihood of you getting down further beyond 50% is more likely. Or this patient had a very high lipoprotein A level, which statins don't treat. You need PCSK9 inhibitors, which are injectable. So a whole different thing. So as we were able to understand this person's atherosclerotic disease better, because we were like, oh, well, this definitely isn't vasculitis, and it's plaque, so let's manage it how we should be able to aggressively manage plaque. I'm just going to go over a few quick cases. So here's a 43-year-old. These are real-world cases from our inflammatory cerebrovascular disorders clinic. And basically, this was a 43-year-old woman who presented with worsening headaches and right leg weakness. And this poor woman works as a librarian, very sweet lady, still my patient, had a history of anxiety and somewhere was diagnosed with functional neurological disorder, thinking that she doesn't have true pathology. But she had a very high up infarct in the left ACA territory, and nobody was picking it up until ultimately, and the other thing was they did an MRA, and it didn't show any vasculopathy up there. Well, because where that infarct is, this MRA doesn't go up that far. So it was missed. And then we did a cerebral angiogram, and we found that there was vasculopathy or vascular irregularities in the area where she had that infarct. And remember I said earlier, what we really want to look at is we've established a vasculopathy, but we really want to understand if there's inflammation or not. So vessel wall imaging, again, was very helpful, but when an MRA can't go that far, the vessel wall imaging in that 3T MRA is not going to go that far either. So here at the Cleveland Clinic, we have a 7 Tesla MRA scanner, and we took this person to 7T, and we were able to see that those vessels were irregular, similar to the cerebral angiogram, and there was inflammation in the brain. So here, I was at least able to establish that she has a vasculopathy, young patient, no other vascular risk factors, has blood vessel problems, has vessel wall inflammation. We said, let's put her to the test. We did spinal fluid testing, and she had that perfect kind of profile for primary CNS vasculitis. So then after having ruled out all these other things, again, on the left side there, like this is all a small vessel vasculitis workup, which was done kind of before she, I think she was in the emergency room when they just reflexively sent all this, but again, a waste of time, a waste of money. This was all large vessel vasculopathy workup to look in the rest of the body, and it was fairly normal. So after having identified that there's an inflammatory process in the brain, there's vasculitis and inflammation in the brain, it's not coming from elsewhere in the body, we ultimately thought, okay, well, can we make this diagnosis of vasculitis in her? She has eloquent cortex, she actually did end up getting a brain biopsy on the right side and didn't show anything. It showed a normal brain biopsy. But again, the vasculitis is on this side. Now, the question I have for you, and I would love for all of you to scan your, take out your phones and scan this barcode for me. And I guess the question here is like, what do you think we should do? Should we repeat the brain biopsy and go into that left side? Should we continue to just monitor her clinically off immunosuppression for a couple of months still? Or should we start for steroids maybe and then wait for more information? Or do we have enough to say that this is a vasculitic process, it's focal, repeat brain biopsy is too high risk, and we should just go ahead and treat with steroids and cyclophosphamide, which is the treatment for primary CNS vasculitis in the brain? Next, please. Look at that. It's like a perfect bar graph in sequence. Excellent. Yeah, so can I tell you that none of these answers are wrong? All of the above have been done, right? So you all can pat yourself on the shoulder. But what would be probably my most appropriate, being a specialist in this field, is I would say I have enough information to say that she has probable CNS vasculitis, and I am probably putting her at more risk for having more strokes if I hold back on immunosuppression from her. So we treat this with high-dose steroids and cyclophosphamide. These people get IV or oral cyclophosphamide for 4 to 6 months, and then we put them on maintenance therapy with an oral steroid-sparing agent, like mycophenolate or CellCept, azathioprine, methotrexate, and then we do repeat imaging on these patients until they're in remission, and then after that, we'll keep repeating and following imaging with them for, initially for a couple months, and then we try spacing it up if they're stable, and then maybe once a year. But the diagnostic dilemma that we have is how long should we be treating these people with immunosuppression? So again, another question for you all. I mean, this person has inflammation. Should we do 6 months and stop, maybe 2 years and stop, maybe 5 years and stop? Or like MS, should these people be on lifelong immunotherapy? Can I just say again, there's no right answer. Again, welcome to my world. So this has been a question that even I have not yet been able to answer. So personally, I think definitely less than 2 years is probably not enough. 6 months is perhaps beyond. So basically, and I'll show you, we have 2 large retrospective cohorts, one out of Mayo and one out of a French cohort study. And basically what they showed is that when you just did induction for 6 months with steroids and cyclophosphamide and didn't then put them on an oral steroid-sparing agent long-term, their chances of relapsing was much higher. The way I tell this to my patients is, your brain and the blood vessels in your brain are on fire, right? So we're going to take out this big fire hose of water, right, like a fire truck, and we're going to spray it all to get that fire out, right? And then beyond that, we are going to also use cyclophosphamide, which is another chemical that's going to try to put that fire out for a little bit longer. But then after that fire is completely put out, and there's all this kind of wood and coal at the bottom, in order for it not to creep up again, we want to lay down a nice layer of insulation so that fire doesn't creep back up and the vessels don't spark back up again. And that is the oral steroid-sparing therapy, or the kind of oral pills that we give them for long-term immunosuppression, which are used in several other autoimmune disorders. I'm sure you guys have heard of like mycophenolate or CellCept or Imuran or azathioprine or methotrexate. So those are agents that we give afterwards. So this patient, in reference, the 49-year-old woman, was started on steroid cyclophosphamide for 6 months, and then on oral steroid-sparing therapy. We followed her for several years now, and she's been very stable on mycophenolate. The other question we often ask, and the dilemma we face, is sometimes patients can present with a hemorrhagic subtype of vasculitis, which is small vessel, and it just keeps encroaching and eating the brain's blood vessels, and they present with hemorrhage after hemorrhage. So this 53-year-old man presented with, he was seen at Yale New Haven Hospital, had a brain hemorrhage, and then a couple months later had a brain hemorrhage, and a year later had another brain hemorrhage, and then a couple months later had another brain hemorrhage, and ultimately got a brain biopsy. And shown here is kind of in white that brain hemorrhage. So a brain biopsy actually showed very necrotizing small vessel vasculitis that wasn't amyloid positive. And ultimately, we know that patients in the retrospective Mayo cohort, about 10% of patients did have hemorrhagic predominant vasculitis, and they were treated very much with the same medicines I told you about and did really well. So that's how this patient was treated, and he's had no further lesions in 2 years. He had significant leg weakness. He was treated here. Some of you may have even been part of his rehabilitation. And he was a retired veteran, now had his own construction company. He couldn't walk, and I promise you, in order to get a 7T MRI on him, since it's only done in Mellon and done in outpatient, I had to wheel him over to Mellon. Me and Dr. Kaja, we took turns taking him over to the Mellon Center to get an outpatient MRI. And his leg was so weak that as we wheeled his wheelchair, his leg would flop and kind of come outside. We had to tie his leg to the wheelchair to make sure that, we don't run an accident out on the sidewalk. And this person 2 weeks ago came back to my clinic. He walks, he's running back his business again. He just got married, a couple months ago. His first wife unfortunately passed away many years ago, so he just got remarried to his childhood best friend. And, so people go on to live a great life if inflammatory cerebrovascular disorders are identified early and treated appropriately. And really, in the future, what we're looking for is to try to find biomarkers that will help us do earlier diagnosis in these patients. And perhaps either their blood markers or spinal fluid markers, imaging markers, so that we can use targeted immunotherapies for these patients. Maybe one person might benefit better from one immunotherapy versus the other. And so the goal is to really focus and move towards more personalized care in these CNS vasculopathies. So we'll go over a few more. The age reference is going to get a little bit older here. So here's this 85-year-old woman who came in with progressive encephalopathy. She was just really altered. She gets an infectious toxic metabolic workup, EEG, CT, everything unremarkable. We do an MRI brain on her, and she has this florid inflammation, all that white kind of material that you see there. It's like her brain is bathing in protein. On the hemorrhage sequences or the SWI sequences, we see that all those little black spots were all kind of hemorrhage in the leptomeningeal cortical blood vessels. And then she had florid kind of leptomeningeal enhancement. So when we see this like hemorrhagic inflammation that's going on, we think either this is a really bad infection, like an angioinvasive fungal infection, like Cryptococcus or aspergillosis, or is this like, normally these things happen in immunosuppressed patients, but this woman was not immunosuppressed, or like a very aggressive cancerous process or a vasculitic process. And, you know, she underwent spinal fluid testing, was floridly inflammatory, like too high to be true. And then she developed status epilepticus, had seizure after seizure, and went into status epilepticus, was treated with many anti-seizure medicines. Ultimately, because of the seizure medicines, as they were up-titrated, she became hypotensive, required to be intubated. Her neurological status continued to worsen, and then she undergoes a brain biopsy. And what this showed was amyloid deposition in small vessel cortical vasculitis, a condition called amyloid beta-related angiitis, or ABRA, which is very similar to CNS vasculitis, but happens in older adults who have amyloid deposition. I know Dr. Rothenberg gave a talk earlier today on some amyloid disorders as well. So amyloid can develop in the brain or deposit in the brain tissue itself and cause Alzheimer's disease, or it can develop and aggregate in and around blood vessels and make them leaky and lead to kind of amyloid angiopathy and leaky blood vessels. So this patient had amyloid-related vasculitis, which is very similar to the primary CNS vasculitis that I mentioned to you earlier, but just that it's treated very similar to CNS vasculitis. The difference being that the primary one that I showed you in that 49-year-old girl initially, or 47-year-old, was idiopathic, and this one happens as an immune reaction to that amyloid. So this lady was started on steroids because she has a vasculitic process. There's no meaningful change. We do extensive antimicrobial testing, and that was negative for an infection. And since she was not getting any better, she gets a repeat MRI. And although some of the inflammation is better, now she has this large macrohemorrhage, this brain hemorrhage up top in the right frontal lobe. So at this point, the family is really, really kind of hopeless at this point and thinking, you know, we should probably not continue treatment. And at this point, when this patient who has a brain biopsy, has a diagnosis, is doing really poorly, the question was, despite steroids, she's not doing really well. What should be the next best step in management? Should we continue steroids for a couple more weeks before deciding on the next step in management? Should we reconsider the diagnosis? I mean, she's had a brain biopsy, but are we missing an infection? Are we missing like a cancer or lymphoma? Or should we go ahead and start cyclophosphamide? But listen, if you're wrong here, you are going to kill this person, right? Because if you put cyclophosphamide on an infection, that's going to disseminate and be the end of that person. Or take a more palliative approach and say she's 85, she's been through a lot. We've tried initially to treat her seizures, they're not getting treated. We've tried some steroids, and she's just getting worse. Should we take a more palliative approach here? So continuing steroids and reimage in a few weeks is a very, very appropriate answer, and probably would have been 95% of the people's answer in the clinical world as well. Cyclophosphamide, are we really confident that, you know, this is amyloid beta-related angiitis and nothing else after that brain biopsy? Or should we take a more palliative approach? So I'll tell you what actually happened with this patient. So after talking to the husband, he actually wanted to go with hospice and make her comfort measures. And I went back to this man, and I remember in age 62, the step down, I was talking to this patient's husband, And I said, sir, listen, your wife has a biopsy-proven diagnosis of amyloid beta-related meningitis. It's a very aggressive vasculitis, but if treated early and aggressively the right way, it can have a favorable prognosis. Can I give her cyclophosphamide? And I'm morally obligated, obviously, to talk to him about the side effects of cyclophosphamide. It's a chemotherapeutic drug. As I start going down the risk of, there can be infection risk, cancer risk, yada, 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 he's like, oh, no, thank you. Let my wife die in peace. And I said, listen, there's a biopsy-proven diagnosis. Cyclophosphamide may work really well. You're going to make her comfort measures anyways. Can I give her 1 dose of cyclophosphamide? If it works, great, we celebrate a miracle. If it doesn't, you're going to make her comfort measures anyways. He says, okay, fine, 1 dose. So we have data from, again, the Mayo cohort that about 20 patients in that cohort had biopsy-proven ABRA and did fairly well when treated just like we treat vasculitis. So this patient gets 1 dose of cyclophosphamide. She started on oral prednisone taper. She's discharged to rehab. She's seen 3 months after with interval imaging, and all the inflammation is gone. And that macrohemorrhage, right, up top will remain. I mean, she'll have some encephalomalacia from that hemorrhage that she had. I never promised that would get better. The amyloid in the vessels is always going to remain, but the inflammation was significantly gone. 3 years later, she's alive. And I can tell you, when she came and saw me 6 months later, she says, why do I need to see you? I'm fine. I'm like, oh, you're welcome. Right? This is someone we're going to send to hospice, right, and celebrate her funeral, God forbid, So no relapses in 3 years. So the point that I want you to take away is inflammatory cerebrovasculars are very treatable. This is very quickly another cerebrovascular disorder that's inflammatory. A 74-year-old woman presents with inflammatory status epilepticus. She has inflammation from these really tiny microhemorrhages, as I've shown you in the arrows on the left, and all this significant vasogenic edema. This meets criteria for a diagnosis called cerebral amyloid angiopathy-related inflammation. Overall, it's treated with steroids. And I'm not going to ask this question, just move on to the next poll if that's okay. But basically, the dilemma in the field is, should all these patients be treated with IV cyclophosphamide or not? Because we treat most vasculitis with this. But the difference is that this is a perivascular inflammation and considerably milder, but can present really aggressive. And so what my research has shown is that, especially driven, the question that I've had is, we take a lot of this literature of how to treat these patients from the rheumatology world. And, I've such a huge deal of respect. I've learned so much from my rheumatology colleagues. But on the flip side, what I say is this is not your 30-year-old patient with psoriasis who you can immunosuppress to their bones, right? This is an 84, 75, 80-year-old, usually more often women. Median age is about 70, 74, 75. These are old, frail patients. Do we really have to be treating them with cyclophosphamide, something so hard? So basically, what we were studying is to identify predictors of relapse of inflammation and how to best treat these patients. And we were able to find that those who present with really florid inflammation up front are the ones who really have a higher risk of relapse versus those who only have mild inflammation perhaps don't. And I'm going to pass through this, but overall what we showed is that those with diffuse edema on MRI had 12 times higher risk of relapsing and having more of this inflammation. And mycophenolate alone after steroids worked really, really well. And we were able to avoid giving these people chemotherapy or with IV cyclophosphamide. So how does this change practice? Basically what we do is we've modified our practice. This paper actually has been submitted for publication and been provisionally accepted in the Annals of Clinical and Translational Neurology. So when we see a patient up front and they have these high-risk features or they have this diffuse edema up front, we'll just put them on that oral steroid-sparing agent. And I tend to keep these patients on for as long as they live because the chance that they're going to have a relapse is going to be really bad. Imagine that patient who presented in status epilepticus, who had a trach and peg, and made it out completely fine now, going back into status epilepticus. She may not make it out after that. So this lady basically had an inflammatory spinal fluid. I was called from the ICU saying that her seizures are just not being controlled with any seizure medicine. The moment we start her on steroids, 4 days later, her EEG quiets down. She has gradual improvement. She needs a trach and peg. 3 weeks later, the inflammation is much better. And 10 weeks later, bottom corner, it's all gone, right? So I put her on steroids, mycophenolate. She's stable beyond 3 years now. I see her once a year. She's reading her books. She's living life. She's doing her gardening, doing really, really well. So just differentiating those ones, the amyloid beta-related meningitis is more of a vasculitis, whereas the inflammatory CAA is more perivascular. They're all treated slightly differently. They overlap significantly with Alzheimer's-related treatments that are being given because these anti-amyloid antibodies can actually trigger and cause CAA and CARI. So people with existing CAA or CRI, they unfortunately are not candidates for some of these anti-amyloid therapies that are given in Alzheimer's disease. And very quickly, another 49-year-old woman presents with headache, encephalopathy, these infarcts all around the brain, particularly in the corpus callosum, had blurry vision. We found vasculitis in her eye, and that met criteria for this condition called Susac syndrome, which presents with deafness, vasculitis in the eyes and in the brain, and again is treated with immunosuppression, but the issue is that this is more an antibody-mediated process as a result of anti-endothelial antibodies. So we treat it more with how we treat antibody-mediated processes are more B-cell-directed therapies with steroids, but IVIG, rituximab, and that's what we treated her with, and she overall is doing really well, and she's a social worker. It's been about a year and a half now, and she's, at least for the last year, has had no relapses. And again, this is something that we're studying in our cohort here, again, showing that cerebrovascular abnormalities are present in about 50% of patients, and they do quite cerebrovascular manifestations in these patients can really highly suggest severe disease, so we should treat them early. I'm going to skip through this, but all I will say is here's another lady who had sarcoid and developed small vessel infarcts again and again, 40 years of sarcoid, but for the last 15 years, she'd been in remission on nothing, presents with progressive cognitive decline, recurrent strokes. Again, ultimately, kind of back to that algorithm, we did cerebrospinal fluid testing, had really inflammatory spinal fluid, and ultimately, after a brain biopsy and multiple workup, we diagnosed her with neurosarcoidosis-associated vasculitis, which can spread to the brain. It responds very well to treatment as well, but again, a different type of treatment called TNF-alpha inhibitors or infliximab, and has done miraculously well. So in conclusion, I just wanted to show that it's been a 45-minute talk and time has flown, and I appreciate everyone's interest. Nobody yawned, which is great. But the spectrum of cerebrovascular disorders, I probably only showed you 10% of it today. It is really vast. But these disorders can be very complex to manage, and really understanding how the variability in them, the way that there's different pathophysiologies that cause different disorders, it's important to identify and rightly diagnose these patients and target treatment according to the underlying mechanisms. And earlier, as I discussed, it's really important that we don't misdiagnose these patients as not having inflammation, as when they have inflammation, catch it early and treat it. When they don't have inflammation, don't mislabel them as inflammation, because the treatments can actually worsen their underlying plaque and other things. We certainly need some more research in this area and more randomized data. But lastly, I will say that really the treatment of these patients with cerebrovascular inflammatory disorders requires a multidisciplinary approach paired with really a great deal of patience, vigilance, and humility. And I really highly believe that it's the best teams that drive the best care. I thank you all for being a part of these patients' journey. They really appreciate all that you all do, from all the ancillary services, particularly from nursing, from rehab, from all aspects of care. And we're only seeing them in the acute period, particularly and my job is a lot easier. This is your diagnosis, here's your treatment. But that journey of 6 months to a year, that really getting them out of that, you are playing the most important part. So thank you for all that you do. I appreciate your attention.